guys, welcome to AMC Doctor. Today in this video we will be discussing the diarrhea cluster. So for AMC Clinicals there are a lot of topics that you need to cover, and it will be really helpful if you can cover them under certain clusters, particularly for medicine and pediatric cases. It's just that you'll be able to cover a lot of topics this way. So now talking about the learning objectives, today we will be discussing the definition of diarrhea, we'll be looking at the causes and an approach to a case of diarrhea. And finally, we'll look at the AMC cases. And all of these are going to be time-stamped in the video description down below. So diarrhea itself is a vast topic, and there are a lot of theoretical stuff that you can cover under this topic. So for AMC, you need to filter the things that you need to study and things that you can omit. For example, the pathophysiology of diarrhea. Honestly, it can be very time-consuming. As long as it's just a quick revision, that's fine, but it's not that important for AMC Clinicals. It's just that all these theoretical stuffs has already been tested during our AMC MCQ examination. So for clinicals, it's better to focus on history taking, the differential diagnosis, patient counseling, and going through the AMC cases, the types of questions that has been asked in the AMC, that would be more beneficial. So now coming to the definition, diarrhea is characterized by abnormal frequency and consistency of stool. So by abnormal frequency, it means that there should be more than 3 motions per day, or a change from previous frequency is considered as abnormal. And consistency, the patient should be complaining of loose, watery stool. Now, looking at the acute diarrhea, it means that it should last less than 2 weeks. Persistent diarrhea means lasting between 2 and 4 weeks, and chronic diarrhea lasts more than 4 weeks. So with this information, what we need to understand is that in history of presenting illness, when we are asking questions related to diarrhea, we need to ask about the frequency, consistency, and duration. And this will ultimately help us to come to a diagnosis. Now, moving on to the causes of diarrhea, we have acute and chronic. So in acute, we need to consider the gastroenteritis caused by the bacteria and viruses. Here also consider food poisoning, and then also consider the antibiotic reactions. Now in chronic diarrhea, the causes are irritable bowel syndrome, inflammatory bowel disease, consider drug reactions such as use of laxatives, antibiotics, alcohol, thyroxine. Then we have chronic infections. The important ones here are Giardia lamblia, Clostridium difficile, Entamoeba histolytica, and HIV infection. And also don't forget to rule out colorectal carcinoma. We have celiac disease, cystic fibrosis, and hyperthyroidism. Now coming to clinical approach, the first thing is history of presenting illness. Here you need to ask more questions related to diarrhea. So ask about the duration, since when, frequency of diarrhea, ask how often do you pass stool per day. Then the nature of stools, you want to know what does the stool look like. Is it watery, loose, or are the stools pale, greasy, smelly, and difficult to flush away? This is typically seen in malabsorption syndromes such as celiac disease and cystic fibrosis. Then ask whether the patient has noticed any blood or mucus in the stool. Now, whenever there is a history of blood in the stool, consider these differentials. These are inflammatory bowel disease, carcinoma, certain infections such as Shigella, Salmonella, E. coli, amoebiasis, and also consider pseudomembranous colitis and ischemic colitis. Then you need to ask if the person has had similar episodes in the past. Then ask, have you been woken from sleep during the night by diarrhea? So this is usually positive in organic diseases, whereas in functional bowel disorders such as irritable bowel syndrome, the sleep is not affected. Then in associated symptoms, you can ask the general symptoms such as fever, loss of appetite, loss of weight, and also ask about the gastrointestinal symptoms such as abdominal pain. To the patient, you can ask if the patient is experiencing any tummy pain. Then ask about nausea, vomiting, and also flatulence. So flatulence, you can ask by saying, are you passing wind more often than usual? Now you want to ask few questions that are specific to your differential diagnosis. For example, if you're considering food poisoning, you want to ask these questions like, where did you eat in the 24 hours before the diarrhea started? What food did he eat during this time? Okay, you can be more specific, like, did you have chicken or seafood recently? You can also ask if there's a history of any other person who got the same problem, like in his family or his friends. Similarly, for irritable bowel syndrome, you can ask about pain which is relieved by opening bowels or passing wind. Ask about alternative constipation, diarrhea, passage of mucus per rectum, or feeling of incomplete emptying of the rectum following defecation. Similar for inflammatory bowel disease, ask about abdominal pain, diarrhea, blood and mucus in the stool. Ask about loss of weight, and also ask about the extraintestinal manifestations, like if the person has had any problems with his joints, skin, or trouble with his eyes. Similarly, in giardiasis, ask about the travel history. If you're considering cancer, you want to ask about loss of weight, loss of appetite, or any lumps around the body. Then if you're thinking malabsorption, you want to ask about loss of weight and stools which are pale, greasy, and difficult to flush. So as you can see, there are so many questions that you need to ask, but again, you need to tailor it depending on the duration of diarrhea, depending on the consistency of stool. And for example, if it's a case of chronic diarrhea, you might not consider food poisoning as your differential, right? So you can omit these questions for food poisoning and focus more on other causes of chronic diarrhea, like maybe irritable bowel syndrome, inflammatory bowel disease, and so on. Now, in past history, ask if the patient has been diagnosed with inflammatory bowel disease. Then in family history, you can ask if there is anyone in the family who has similar symptoms. And this is particularly for celiac disease, Crohn's disease, cystic fibrosis, and also ask about any history of bowel cancer in the family. Then comes travel history, again, very important question that you need to ask if you're thinking of infective causes. So ask if the patient has traveled overseas recently, and if it's a yes, then you might want to ask more questions like, where did the patient go, what sort of lifestyles did he live when he was in that destination. And finally comes the SADMA. So ask about medications, be particular, like if the patient is taking any antibiotics, any vitamin supplements, laxatives, and also ask about the alcohol history. Now coming to PEFE, ask about the general appearance. Then comes the pill cycloid. Here, pallor and dehydration is very important because, if there is a history of bloody diarrhea, so pallor might be a finding. And because it's diarrhea, you might have various degrees of dehydration. But again, if there's any other relevant findings that you're expecting, you can always ask them. And then comes BMI, because there might be history of loss of weight, especially in the malabsorption syndromes. Then ask about the vitals. Then you can examine the thyroid for any enlargements. Now, this is important if you're considering hyperthyroidism as your differential. And yes, now comes the abdominal examination, which is the most important part in PEFE. And you have to do a detailed one. Start with inspection, like if you can see any abdominal distension, any scars. Then on palpation, if there is any tenderness in any of the quadrants, and maybe if there is any organomegalies. Then on auscultation, ask if you can hear the bowel sounds. And here, don't forget to do the digital rectal examination, and also mention that you'd like to do that with the presence of a chaperone and with the consent of patient. Here you'll be looking for any skin tags, fissures, fistulas, and abscesses. Then you can quickly go through the cardiovascular system and the respiratory system examination. Now, if you're thinking of inflammatory bowel disease as your diagnosis, you might also want to ask about the extraintestinal manifestations. And here, as you're talking to the examiner, you can use medical terms. So you can ask, I would like to examine the eyes, and I'm looking for any for signs of episcleritis and uveitis. I'd like to examine the skin, and I'm looking for signs of erythema nodosum, pyoderma gangrenosum. And you can also mention that I'm looking for signs of ankylosing spondylitis, sacroiliitis, or any peripheral arthritis. Now we'll start with the AMC cases. So this is our first case. You're a GP and your next patient is a 30-year-old male who comes to you with chief complaint of chronic diarrhea for the last 2 years. So your task is to take a history, PEFE, diagnosis, and differentials. So as so far we have already discussed an approach to diarrhea. So you need to apply the same principles to perform these tasks. So when you're starting to take history, you'll get these positives. So the patient is having diarrhea for 2 years, which worsened in the previous 2 months. The frequency is 5 to 6 times. It's on and off. The consistency of stool is watery. There is presence of blood and mucus in the stool. And you'll also get a positive history of loss of weight and stomach cramps. So, a young patient who has come with a history of chronic diarrhea with blood in their stool, it's most likely a case of inflammatory bowel disease. But you need to consider all these differential diagnosis, all these causes of chronic diarrhea, and ask the screening questions in the history taking to rule them out. And because it's a case of bloody diarrhea, you also want to consider chronic infections such as Entamoeba histolytica, Clostridium difficile, colorectal carcinoma in your differential. Then you ask about the past history, family history, travel history, and SADMA questions. Now, for inflammatory bowel disease, a history of smoking is very important because smoking can increase the risk of Crohn's disease. And once you have it, smoking can make it even worse. But in case of ulcerative colitis, smoking helps in prevention. But again, we all know that smoking has harmful effects on our overall health, and it outweighs any benefits. So always encourage the patient to quit smoking. Now coming to PEFE, there are 2 positives for this case. So first is pallor, and the second one is mild tenderness on all quadrants. But again, please don't forget to ask about the extraintestinal manifestations, the stool microscopy, and digital rectal examination findings in this case. Now, when you come to the diagnosis, there are 3 things that I want you guys to pay attention to. The first one is when you're explaining the condition to the patient, try to use simple layman's term. And the second thing is that there's going to be a pen and paper inside the room. So utilize it to draw some simple pictures which will help you explain the condition to the patient. And the third thing is that you need to correlate the symptoms that the role player is having with the diagnosis that you have come up with. Okay, now so for this case, you can begin as by saying, based on the information that you have provided and on examining you, most likely what you're having is a condition called inflammatory bowel disease. Okay. And at this point, you can also draw the picture showing the digestive tract, show the large bowel, small bowel, and explain this to the patient. Okay. And so in this condition, what's happening is that there is inflammation of the bowel. And that is the reason why you're having diarrhea and blood in your stools. Also mentioned that there are 2 types of this disease. One is ulcerative colitis and the Crohn's disease. Okay. The second thing is you can show it on the picture that you have drawn, that in ulcerative colitis there is inflammation of the large bowel, and in Crohn's disease there's inflammation of the full thickness of the bowel, but it can involve any part of the digestive tract from mouth to the back passage. Okay. So that's it. Keep it simple. So then you can move on to giving your differential diagnosis. So when you're giving the differentials, don't just list them out. Rather, what you can do is that you can just mention a few lines about how you rule them out. Like, for example, in this case, you can say that, apart from this inflammatory bowel disease, I was also thinking of like chronic infections like giardiasis, amoebiasis, but unlikely in your case because you do not have history of fever and no significant travel history. And I was also thinking of maybe it's due to some medications, but it's good that you're not using any sort of medications. And I was thinking of like irritable bowel syndrome, but because you have a history of like blood in the stools, so it's very unlikely. Okay, so you can give at least 5 to 6 differentials, and explain them how you ruled them out. Now coming to the second case. So this is the question. A young female is at your GP practice today for reviewing her results of colonoscopy, in which the biopsy shows ulcerative colitis. She had chronic diarrhea for the previous 6 months, which is 6 to 7 times per day. There's blood present, no mucus, and specialist has referred her to you so that you can explain the disease and counsel her accordingly. Task is explain the condition and management. So in this case, the diagnosis has already been given. It's ulcerative colitis. So you don't need to take further history. Now, this is a counseling station. So you need to explain the condition in detail. So in these counseling cases, there's a thing called 5C approach, where the first one is condition. So you need to explain the condition to the patient. Just like in the previous case, you can draw a picture, show the digestive tract, the small bowel, large bowel, and then you can define the ulcerative colitis. You can show which part of the bowel is affected, and then also mention about the symptoms, and you can also correlate it to the symptoms that the patient has been presenting with. Then comes commonality. Ulcerative colitis is quite common here in Australia. Then explain the cause. So for cause, in ulcerative colitis, it's there are several factors that is responsible for it. So there's a genetic factors, there is environmental factors, and abnormal immune response. So a combination of these factors causes a person to develop ulcerative colitis. And then talking about the complications. So in ulcerative colitis, you can tell them that, in addition to the bowel that's being affected, it can also affect other organs like the skin, joints, eyes. And in severe cases, it can cause rupture of the bowel. It can cause problems with the bile ducts and affect the liver. It can also cause a condition called toxic megacolon, where a part of the bowel gets dilated and it's prone to rupture. And don't forget to mention that in long term, it can also cause an increased risk of developing bowel cancer. And when you mention this, the role player can become anxious. Okay, so try to give reassurance. Tell them that you will follow up him regularly, and you will and the risk of developing cancer can be decreased by eating a healthy diet, exercising regularly, avoiding alcohol and smoking. And finally comes the course. Okay, so you have to tell the management. So in the treatment, you need to mention that ulcerative colitis, it's a chronic disease that you'll have for the rest of your life. It's not curable, but the good news is that it can be controlled with treatment. And if the symptoms are under control, the person can have a normal life. And currently, there are a wide range of treatment options available for ulcerative colitis. So you can mention about the medications. So you'll be given medications that will help you reduce the inflammation and allow your bowel to heal. So medications such as steroids and aminosalicylates will be given. You might be given medications that will suppress your immune system, called the immunomodulators. And you might also be given antibiotics in presence of infection. You'll be given supplements to treat the nutritional deficiencies. And in severe cases or cases where your body is not responding to medications, surgery is an option. Okay, and mention that it's going to be a multidisciplinary approach, that you as a GP and the specialist will also be involved to take care of the symptoms. And also mention that there will be regular follow-ups so that the symptoms are under control, and you will be also monitoring for any side effects from the medications mentioned above. So these are just the theoretical points that you need to cover for this station. But in any counseling cases or whenever you are interacting with the patient, it's very important that you make it very interactive. You should be able to engage the person in your conversation, and also check that the role player is understanding whatever you're explaining. You can ask them that, are you following me, are you able to understand, and also tell them that you will repeat any point that they don't understand. And this is a very important point for your AMC, and it's considered as a part of your communication skill. So try to avoid bombarding the patient with all these theoretical information and causing unnecessary concern. It's inappropriate, and you can even lose a station because of this. So in all cases, along with the theoretical points, make sure that you're displaying empathy and providing reassurance every now and then. And try to practice this as much as you can during the role plays, so that during the exam it comes more naturally. So that's it for this video. I hope it was useful. Thank you so much for watching.